So thanks so much for coming, everyone. We're super excited to have you guys here. We have an amazing lineup of speakers here tonight. And my name is Anna Potapov. I'm head of medical networks here at RubiconMD. So as you may know, RubiconMD is an e-consult platform, so electronic consultation platform, where we're connecting primary care clinicians to specialists for expert opinions. So for example, a primary care clinician sees a patient in their clinic and they have a rash, they're not sure what it is, and they can actually take a picture of the rash, submit it on their phone or through their computer, and then get a response from a dermatologist in a matter of minutes to hours, and really help their patient who would otherwise would have had to wait 2, 3, 4 months to see a specialist. So we've been around for 5 years now. Our primary focus is on improving access to specialty care, so focusing on community clinics, FQHCs, also remote locations, employer on-site clinics and health systems is also part of our mission. And myself, I am an orthopedic surgeon by training, so I trained in Canada and then pursued an MBA at MIT Sloan and transitioned into this healthcare tech world, and have been here for 2 years now. So just remembering my experience in ortho, I would see patients who, a lot of them would not actually have to be seen here, so ankle sprains, small fractures, and they would travel hours to see me. They would spend hours in the waiting room just to see me for 5 minutes, tell them physio and anti-inflammatories will do it for them. So obviously that could have been done in a primary care clinician's office if they would have known what to do, and that's where we come in. That's where our value is to provide quick opinions to primary care clinicians that they can have a profound impact on their patient and patient outcomes, and also on their growth as clinicians and learning experience. So today's, we are at the forefront of innovation in healthcare, and that's why we thought it would be a great idea to bring experts in the field, physician executives, and talk about innovation in healthcare. So that event is actually part of our CME program. It has been approved by the AAFP and also accepted for credits by the AAPA and ANP. This event qualifies for 2 CME credits. So if any of you are interested, you'll be also actually receiving an email after the event with a survey to get the credits. We have a really exciting program of CME events lined up in the past year, and also upcoming events. Actually next week, we're going to be covering colorectal cancer screening, and July 18th. And then in August, we're going to be talking about inflammatory bowel disease. And these topics essentially are going to be discussed in a webinar format. You're welcome to join as well, and any primary care clinician on our platform and is invited. And also, if you're interested to join, you can email us and we'll add you to the list. But essentially, we're basing these topics on e-consults submitted on our platform, and we have a great team working on selecting them, preparing the event, and part of this team is myself and Dr. Wanda Olayola, who I'm just going to quickly introduce. She is our Chief Clinical Transformation Officer, and she will be moderating the panel. So I will pass it on to her. Thanks again.
Thank you, Anna, for the introduction. And I just want to do a couple logistic things before I do start. The bathrooms are outside and through those glass doors past the elevators that you came in case you need to take a biologic break. And we also do have people on the live web stream that's happening at the same time. So we're going to be encouraging questions at the end. If you have something that's burning and you just feel like you've got to get it out, we'll go ahead and hand you the mic. But we're going to try to hold questions until the end. So as Anna mentioned, my name is Dr. Wanda Olayola. I'm a family physician, and I'm the Chief Clinical Transformation Officer here at RubiconMD. I've been here for a little bit over a year. Prior to that, I was the director of University of California, San Francisco's Center for Excellence in Primary Care. I was there for 4 years, and prior to that, was the chief medical officer of a network of community health centers in Connecticut. And one of my former colleagues who used to work with me, one of my medical directors, is actually here with us tonight. I'm so excited to see her. But in all these experiences, I have been really wrestling with this issue around how do you make primary care better, and how do you make it work better, not only for those of us that are delivering the care, but for people that are receiving the care. and for people that are affiliated with the systems and that kind of contribute to the overall care delivery system. And so one of the things I've struggled with a lot has been, as a chief medical officer, having primary care providers burning out really quickly, wanting to leave or exit practice, having patients that are really dissatisfied with the way we're taking care of them or the kind of services that we're providing to them, or not being able to get access to services that they actually need. And then also just our healthcare system just costs so much. And you would expect that, you know, when we're spending 17% of our GDP on healthcare, that we would have fantastic outcomes. And then when you look at what we're doing, we're actually not doing that well. We score the lowest, and you know, compared to other industrialized nations on almost all markers of healthcare quality and access and cost. So we're here tonight to figure out like why we need more innovation in healthcare. And we tend to be really, really reluctant to say those words together, innovation and healthcare, because we think, you know, healthcare is just this sacred place where you can't do anything different. We just got to do what we've been doing. We're here tonight to kind of talk about let's challenge that status quo. And if we keep doing what we're doing, we probably will still get what we're getting. Before I do that, I want to just do a quick pulse, like just check and see who's here. So do we have any clinicians in the room? Nurses, physicians, PAs, other healthcare providers provide care? Okay. How many people are healthcare administrators? Service care. Okay. What does this mean? I'm kidding. Okay, so kind of. Anybody from a tech company? Oh wow. Okay. Oh, all right. Any other startups represented here? Oh wow. Any lawyers? Okay. Any journalists? All right. Okay. So any students? Anybody that's a student? Okay. Oh wow, we have a lot of students. Okay, great. Well, thank you all for being here, and thank you for the people that have joined online. Okay, so I'm going to go ahead and introduce our panel. I'm going to just introduce them all and then have them tell you. We're going to have them each take a couple minutes and tell you about themselves. But Dr. Toyin Ajayi is the Chief Health Officer at Cityblock, and she's going to tell you more about Cityblock. Dr. Tom X. Lee is the founder and executive chairman of One Medical, and Dr. Vivek Garg is the Chief Medical Officer of Network and Business Development at CareMore. So we're going to start off with a softball, because we're gonna get to harder questions later. Like, I know you guys want the hard questions, right? So we're gonna start off with the easy ones, which is just tell us about your organization and kind of what you guys do.
Okay, that one I can do. So my name is Toyin Ajayi. I'm a family physician. I have the incredible privilege of being one of the co-founders and the Chief Health Officer of Cityblock Health. We're a New York-based startup. We launched last fall. Focused on Medicaid eligible individuals and folks who are dually eligible for Medicare and Medicaid. And our focus is really on transforming the care experience for underserved populations, individuals with complex health needs. We have a particular focus and interest in people with complex polychronic medical needs, as well as people with serious mental illness, substance use disorder, and all of whom are struggling with the challenges that go along with poverty and lack of access to effective social services. Our model is predicated on the notion that primary care, integrated holistic primary care, partnered with mental health services and social services, is the bedrock of improved outcomes for patients and for communities. So we focus on partnering with payers and at-risk providers and taking financial risk, for the total cost of care for individuals with complex needs, and for delivering direct to them primary care, behavioral health services, substance use disorder treatment, social services coordination, and partnerships along the continuum of their care experience.
My name is Tom Lee. Nice to meet you. I'm originally trained as an internist. I'm mostly a healthcare entrepreneur. I spent my early days doing mobile health at Epocrates, doing some of the early design on Palm Pilot. I hate to say that because it just dates me, but it'll give you some sense. And then built out a company called One Medical, which is kind of a next-gen primary care model. It's one of the largest pure national primary care models, particularly on the commercial side. And then some folks know on the inside that I'm working on a new company that is looking at Medicare and Medicaid primary care delivery as well. So that's kind of been my background. No.
Hey everyone, Vivek Garg. It's really a pleasure to be here. I'm an internal medicine physician as well. And initially, thank you, Tom, for my first job out of training. I worked at One Medical Group in New York for 2 years as a medical director and internist. amazing experience and really unique. I then spent some time at Oscar Health during its early phase of building out internal functions around medical management. And now I lead growth and new product and program development at CareMore. And a little bit of backstory about CareMore, probably the best way to convey it is sort of my progressive understanding early on when I was exploring a job opportunity with them. CareMore's been around for 25 years. It was founded as a medical group in Southern California by a physician entrepreneur named Dr. Shelley Zimberg, who's about 92 years old, still shows up on video conferences, can bench press 250 pounds and do handstands. So a very unique person who essentially with his practice looked at the care that his frail seniors were getting from him and his colleagues and felt like they could do better. So they were looking at their own patients getting admitted to the hospital, and the primary care team didn't know about it. They were looking at patients who were newly diagnosed diabetics who were being started on insulin, and they were trying to see them for 15 minutes, and then they walked away with insulin, their A1C didn't improve, and they questioned why. And they said, maybe we can do something different here. So the CareMore story is one of a clinical organization founded by clinicians oriented around redesigning care for the highest need patients. We launched something called the extensivist model of care, which is where we now have physicians and nurse practitioners who don't just manage patients in the hospital, they actually actively divert them from hospitalization in the ER into their own care at skilled nursing facilities, into our care centers, or even into the home increasingly. And CareMore built a philosophy of integrated care over 20 years ago, and then lost a lot of money because it built a lot of services that were not funded under fee-for-service, podiatry, home-based care, lots of things that have very incremental value or aren't valued at all. So long story short, the organization then started a Medicare Advantage plan when Medicare Advantage started. And that was really to gain control of the financial risk, as people mentioned, but also the levers of network, benefits, utilization management, and other things. So what attracted me to CareMore is that it's very grounded in patient care, a very holistic mentality, and we've evolved significantly in the last few years. So we're now in 10 states as of last week. We now work with high-risk patients in Medicare, Medicaid, dual eligible, soon high-risk commercial. We're actually owned by Anthem, the very large health insurance plan. And I'd say that the tailwinds there are that I think payers have seen that something different needs to happen in healthcare. And the heart of where that needs to happen is with patients, with clinicians, and how everybody works together. So that's just a little bit about CareMore.
Thank you. All right, so I'm going to direct my first question to Toyin. So when people criticize healthcare innovation, it says a lot of times what I hear is that you can't have it all. You can't have a model that's going to address health disparities and really provide good care for vulnerable populations, also address the community needs that are present, and do it in a sustainable business model. So can you just talk to us about why Cityblock thinks that they can do this and no one else seems to be able to crack that code?
Sure. I mean, part of it harkens back to your comments earlier, which is, our status quo doesn't work. We know that. Fee-for-service healthcare. And, for us, it always comes back to the patient journey, to the member journey. And so just even walking through it exposes the gaps, right? So we have people who we in the medical system call, in pejorative terms, non-compliant or non-adherent. These are folks who show up in the emergency room frequently for things we think could be managed better in ambulatory care settings. These are folks who have disproportionately high costs of care. These are folks who make a lot of the healthcare system feel oppositional towards them. They're angry, they're frustrated, they don't do what they get told to do. And our traditional medical system, which gives 5 to 7 minutes per provider per visit, even if you were seeing this patient 3 times a year or 4 times a year, when we know actually on average, less than a third of patients with complex needs and high cost actually have a usual source of care. There's no way you could meet those needs. And so what we have is in addition to really high costs, really disproportionately poor outcomes. And when you talk about health equity and you talk about decreasing disparities in care, it is fundamentally an issue of the fact that we have not applied the right care model to the folks who need it. And there's 2 kind of underpinnings of this. The first is identifying people with complex needs. And so even the notion that we would stratify a population is kind of new to healthcare in many ways. I think we're trained in healthcare as physicians to think that we treat everybody exactly the same, and that is a virtue. We don't need to know if this person has Medicaid. It shouldn't matter. It shouldn't matter if this person is homeless. It shouldn't matter if this person is living alone, because we treat everybody the same. And actually what we know is that equality is very different from equity. And if we're looking to achieve high outcomes for our populations, we actually have to treat people differently on the basis of what their needs are, and we have to understand what those needs are. And so I actually believe, to come back to your question, the only way we can achieve better outcomes and lower cost in a sustainable way is by transforming the way we deliver care. That's by saying, firstly, from a payment structure, that we are incentivized and we are funded in a total cost of care capitated way, so that we're moving away from the notion that success for me as a physician is, did I write a prescription? How many prescriptions did I write? How many patients did I see? And actually tying ourselves to outcomes. The second is that we are incentivizing a whole different set of key performance metrics. Those are about engagement and about trust and about longevity of a relationship. It's not about the number of people I saw in my clinic. It's about actually meeting people where they are, understanding that where people have differential needs and meeting those needs. And we firmly believe, and I think have demonstrated in various other settings, including the organization where myself and my co-founder Aya Ram came from, that by doing those things, by developing care models that differentially care for folks based on their needs, that understand their holistic needs, that take a full total cost of care view on their lives and their outcomes, you can improve quality, you can decrease cost, and you can certainly improve satisfaction of patients and communities.
Great. Thank you. And they're hiring, so there were some clinicians in the room in case if you're thinking about that kind of role, certainly talk with Dr. Ajayi. All right, next question for you, Tom. So we talk a lot about patient-centered medical homes and patient-centered care, and people think that as you kind of advance technology in a care delivery setting, that you decrease the touch. So, the higher tech you are, the less high touch you are. I'm curious if you can talk a little bit about how One Medical has really been able to be both high tech and high touch and really meet patients where they are.
Yeah, I think that's the counterintuitive thing. I think most of us probably kind of believe in that thesis, which is tech enables higher touch, right? So, tech is great for automation, for very simple things, and enabling communication. And the more kind of you can get rid of the simple transactions and the things that don't need to be readily addressed in person by a human physician, the more than the human physician can actually deal with stuff that's much more complicated, personal, relationship oriented. So it's counterintuitive. I think most people don't realize that One Medical is also a lean model in addition to a high touch model. We are able to do the model that we do because we've re-engineered our cost structure to be about a third the overhead of traditional doctor's offices. That doesn't happen for free. That's all through tech and process design. And so that's kind of how it works for us.
Thank you. All right, so I have a number of friends who, and colleagues who work for CareMore. They're physicians that provide care at CareMore. So I have a little bit of insight into something. But the thing that I keep noticing about them is that they always seem happy. And that shouldn't be a big...
We have different conversations with them.
Well, at least, from what I hear. And you described this extensivist model, which, really sounds like highly intensive for the primary care provider, but truly patient-centered. And so I'm just curious, how do you have people engage patients at such a high level, an intimate level, at so many different places that they traverse in the healthcare system, but also keep your providers so happy?
Yeah, I think it's fundamentally about finding the right people and liberating them to do the work they actually want to do. Looking for fit for people who want to actually understand a patient's social context, who want to actually ask somebody how they're getting home after the discharge. That's not every clinician. And maybe you were that way early on, and maybe it's been suppressed out of you, and it can be reactivated, or maybe it was never your focus in your clinical career. So definitely one part of the match is finding people who want to do the hard work that entails what I think we're all trying to accomplish in our organizations. The second part is the freedom and liberation part, which means that you have to create a structure in which they can actually do that. Like technology and process are significant factors, but when I was joining One Medical, I told my dad, who's a practicing doc in New Jersey, he got really concerned. I never told Tom this, but various CMOs and chiefs of staff from the hospital he worked at emailed me long diatribes, and it really hinged on one statement I made where he said, Dad, isn't it awesome that I could spend 30 minutes with a patient? And all of his colleagues said, why do you need 30 minutes with a patient? You should be able to do it in 5 minutes. And sure, you can do it in 5 minutes, but you don't form the relationship that causes people to call you when they have a real concern, that causes them to come back when they have many other things to do. So I think one fundamental part on the other side of the matching equation is, and we still have work to do here at CareMore, is to create a structure which people can practice in a way where they feel like they're doing the most meaningful work of their lives. You have to be under financial risk. I think you have to actually have more time with patients. Time is attention, time is understanding needs, time is human relationship. Health is about human relationships. So fundamentally, our clinical volume expectations for inpatient and outpatient providers is about half to a third. So our extensivist team may manage a census of 6 to 8 patients in a hospital, walking side by side a peer who's on a hospitalist team that's not affiliated with us, who has 25 or 30 patients to round on. And the math just, when you think about it that way, it just, you're getting less care, you're getting less attention, you're getting less depth of engagement. The other part is I think you just need to equip people who have the time to go deeper because of the financial structure underpinning things with more resources. And I don't know if anybody saw the article by Drew Culler in the New York Times a couple of weeks ago. I forget the title, but it was basically saying how we're asking the people in our communities who are doing the hardest work with the most complicated patients to do more with less. And so to be able to invert that cycle, you have to take control of the financial resources. That's something CareMore's done for over 15 years, and Toyin spoke to earlier. And then you've got to utilize it to plan case management, behavioral health care, social workers, all these other perspectives that when people can actually operate with space and time and engagement, they can actually solve these multidimensional issues in a much different way.
Thank you. Actually, you kind of led into the next question. So I'm going to actually address this question to all of you and you can each answer. So you started to allude to kind of this larger medical neighborhood, and we tend to think of primary care as, in some cases, central to that medical neighborhood and having responsibility to connect and engage all other components of the neighborhood. Could you guys each maybe share some examples of how your organizations are leveraging either technology, human resources, a kind of workflow redesign to better coordinate care in the larger medical neighborhood?
I'll go back to the financing angle. So CareMore in 4 states, soon in multiple other states, cares for about 90,000 Medicare Advantage patients under full global capitation. And we build our own networks, we contract with specialists. And I think that the reality is you can only get so much until you also change the specialist structure and the other partners in the community. And so we use our primacy of financial ownership to actually impart that kind of connectivity to others. And for very highly aligned specialty groups, so we'll do sub-capitation, we'll actually help them change their workflows, we'll connect them on our platforms. And again, it's not asking people to do more with less, it's asking them to do something differently with more. And I think that's fundamentally an angle of how the medical neighborhood needs to come together that's not typically talked about, and technology and process certainly will get us a part of the way there, but then everybody's operating the same 10, 20, 30, 40 visit a day kind of a mentality.
Maybe I can make it a more general statement. So the whole value-based architecture is premised on the fact that primary care is 5% of spend, and there's a lot of downstream spend. So the value-based architecture works in that context. And so when you look at different populations, there's aggregation touch points. And with commercial, which is what One Medical is primarily focused on, you really can't aggregate individual lives because there's no common touch point per se through the commercial markets and all the different plans. But an aggregation touch point from the commercial side that we used was predominantly employers. So the employer-based risk model works. The challenge there is it's a little bit easier than the quote Medicare and Medicaid markets because you're aggregating lives at the employer. It's a homogenous group. They have a common central locus usually. So on a relative coordination basis, I think commercial is a lot easier, and the acuity leverage is not as significant as Medicare and Medicaid. So the benefit of focusing on Medicare and Medicaid is the dollar amount is much more significant. The leverage opportunity is more significant. Obviously, that's kind of the focus of my new org, but the aggregation points are not as natural. And Toyin probably can speak a lot more to the kind of the best aggregation points. But I think that's the key question: is how do you organize and figure out kind of the locus of aggregation?
I love that idea, actually, and it certainly ties into, I think, a lot of the way that we think about the medical neighborhood, as you described, as actually being outside of the medical system as we currently think of it. And so we think about community-based organizations and social services touch points as potentially some of those aggregation points. The challenge with those is they're not concentrated, and so they're quite diffuse. But what we find in our population is that folks are touching social services organizations, housing advocacy, food pantries, shelters, the church on the corner, the community center, multiple times a week, and where they may actually have no meaningful touch points with the healthcare system. And so there's two kind of challenges incumbent on us. One is, how do we partner effectively with those entities in order that we can start to leverage some of the trust that they've built with the patients and the consumers and the communities we're trying to serve? And the second is, how do we identify where actual financial risk or subcapitation or subsidy or partnership from healthcare to non-healthcare entities will beneficially impact our patients and our communities? And it's interesting to be in this at this moment in time when we're sort of, social determinants are the nom du jour right now, and we're constantly talking about how exciting it is that healthcare has discovered that there's all this stuff that happens to people and like the 99.9% of their lives when they're not in front of a doctor, and wow, we should do something about that. The question is what, and how do we partner effectively without subsuming, or actually, I think the risk with healthcare is frankly that we take it apart and translate it into the sort of transactional world that we understand in healthcare. And so there's a lot of really interesting work to do, and we certainly have spent a lot of time thinking about, very intentionally, about how we build partnerships with community-based organizations that are the natural aggregation point for our patients and members in a way that allows us to partner and support and to sometimes kind of ride on the coattails of the trust that they've built, but not in a way that seeks to dominate or to own it. And I think that that's a really important component and something that I think healthcare struggles to learn in general, but that is really key to being effective in these populations.
Great, thank you all for that one. Okay, so I'd be totally remiss if I didn't talk about specialty care, which is kind of where we spend a lot of our time. And one of the things that was most frustrating to me, and has been very frustrating to me as a primary care provider, is having the inability to get my patients access to specialty care when they need it. And we see a lot of different opportunities in virtual medicine to be able to address that kind of challenge. So I'd love for you guys to comment both on, is virtual medicine kind of a solution for that set of challenges, particularly for your patient populations? And if not, what is?
I'm happy to start. I'm holding the mic. I think that virtual care, virtual kind of solutions are really helpful, not just in providing access, which I do agree with you is a challenge in lots of parts of the country. Interestingly, New York is a sort of interesting place where you can't quite cross the street without tripping over a doctor of some sort, and the specialty profusion is really quite remarkable. But I think, and Vivek can probably speak to this as well from the CareMore experience, part of this is not just access, but it's about being able to co-opt the specialist as part of your care model. And I think we spend a lot of time, even when our patients and our members have access to specialists, trying to understand what they're doing, trying to stop them from doing things that perhaps won't be beneficial to the patient in the long run, and trying to impart the knowledge that we have of the patient's holistic care needs to that specialist to help guide their decision making. And so having access to tools like e-consult services that allow us to still maintain control and still maintain insight into what that input is, and to use it as part of an overall attempt to then shape and guide and inform our patients' choices is actually a really powerful tool, even in a place where access per se is not necessarily limited.
Yeah, my only add-on, and I'm a big, I totally agree with kind of the comments there, is the virtual specialty consult, especially enabling the care team to do better work at higher quality without having to kind of disrupt the relationship, is fantastic. The unfortunate nature is obviously the payment architecture doesn't really align with that in today's model, and so that's the frustrating point for sure. I think there's a curation problem, there's a virtual access problem, and the payment problem, but I think it is the future of where healthcare should be, and obviously the right organizations that can enable that through the right models, I think will win.
Yeah, I'll just add, we have a big push in virtual care, but really about enabling those interstitial points around care episodes that don't necessarily need to be in person. Fundamentally, a lot of our patients need in-person attention. There's minute changes. There just needs to be a more human interaction and a more of a holistic assessment, but certainly that leads to a difficulty in scaling high cost, because then you say everything has to be in person. For our specialist colleagues in our networks or our partners who we work with, and we do actually employ some specialists, we look for folks who, again, kind of match the desire to operate in that kind of medical neighborhood model. The other folks, actually, if you just don't refer to them, they're not sure what happened. And so we've been fortunate in that in all the communities we're in, we're able to find those folks, and then the methodology for connecting to them in a meaningful way so that it makes sense for them, there's value for them, technology is a part, so we use Tiger Text right now, we're in discussions with Rubicon. I just think there's a lot of opportunity to do the things everybody mentioned. And then again, there's a integration function, which for the right folks could be actually, fully integrating your care for a segment of patients, and then that financial layer can come in. So I think the combination of virtual and in-person so that you don't lose the story. Everybody is so frustrated by going from one clinician to another, virtual in person, don't have my records, don't know what somebody else said or thought. And probably one of the most important things that could happen for any of our health is for our primary care clinician to talk to our specialist, even if it's by a simple phone call about something that they're considering a decision around or assessment on.
Great, and I think we have some of our specialists in the room, so I'd love to hear some of their thoughts on that as well. Okay, so my final question is, and then we'll open it up to you all to ask whatever you've got, is back to softball. So this is, I'm gonna ask you to push you a little bit. So you are all physicians who are straddling kind of both healthcare delivery as well as business and technology and in the startup space. I wanna know what you've learned. If you were to talk to a younger you, not to say that you're not young, you're all super young, and but a younger version of you, what would you tell them about this transition or this kind of hybrid of the careers that you guys have made?
I'll start briefly, just say that I think there's an amazing emerging opportunity to practice in a way that fulfills the reasons why you went into healthcare. And I think that requires still being risk-taking, changing things up, looking for newer settings, going to the leading edge of the organization you're in, pushing that organization. But fundamentally, how things should be reoriented around what patients say and think and need, and what clinicians who are trying to care for them say and think and need. And so I think there's just an exciting movement, particularly with efforts that this group represents and others here in the audience, about seizing those. And I see a lot of clinicians who, whatever their stage of experience, whatever their age, kind of are seeing it and trying it out. And that's one of the best joys I've had at CareMore, where we've launched 3 or 4 new markets in the last 2 years. It's going to a place like Connecticut, where there's a very heavy density of traditional fee-for-service practice. People practice in hospitals as hospitals, people practice in primary care with 40 visits a day. And we just were able to find a bunch of clinicians who didn't know who we were or what our practice style was. But when we explained it, said, oh, that's why I went into medicine. That's the kind of thing I want to do. And so then they join the team and they see that it can be real.
Yeah, the only thing I might add is, I think everybody's got their own little individual paths. I think the training that we go through to become a physician and then a resident and ultimately a practicing clinician is very different than the type of skills you need to be a good manager and or an entrepreneur. And so I do think good soul searching before you make any path change is always a good idea, and an assessment of your core skills and strengths. I can just tell you anecdotally from me, I love being a clinician and a clinician scientist, but I had troubles getting more excited about the micro and the one-on-one kind of impact, knowing that the whole ecosystem was just crumbling. So for me, out of necessity of having impact, I wanted to work on the broader picture, which I rolled the dice. Fortunately, I got into business school, and then fortunately had some knack at some of the tech and business stuff, but I wouldn't have naturally guessed that I had that instinct or skill set, but fortunately it worked out.
Yeah, I still sort of pinch myself and wonder how I ended up here. I'm certainly not an entrepreneur by nature. I think when I look at sort of my path and I look at a lot of my peers who are, in traditional primary care, in clinics and approaching burnout, frankly, this is the sort of phase that they're in. I think the thing that distinguishes us is that there was probably a combination for me of a little bit of bullheadedness and some hubris that said, hang on a second, like this doesn't feel right. What if it's not me? What if it's the system? And what if I can do something to build a different and better system? And I think actually the advice I would give to people kind of going into medicine is if you wake up one day and you look around and are just like, this isn't what I thought I would be doing. I don't feel good. I don't feel like I'm helping people or having the impact. I think that the natural inclination of the types of folks who tend to go to medicine, type A people, achievers, is to put your head down and just keep hammering at it. And I would say, pick your head up for a second and ask the question. Maybe it's not me. Maybe I can't fix this by being more efficient, coming in earlier and prepping my notes so I can get through the EMR all day, or staying up late on the weekend and writing my notes, or doing whatever it is I'm doing to make it work. Ask whether the system's broken, and then ask yourself whether you're willing to be part of something that might change it or redesign it. And I think that's, in so many ways, I think that's part of how people get trapped in a system that is not set up to actually improve outcomes for patients and to derive satisfaction for providers in it.
Thank you all so much. A round of applause for our amazing panelists. So we're going to open it up to you. What we'll do is Dr. Padapov, Anna will walk around with the roving mic. Please, when you ask a question, we would love for you to just say your name and your affiliation, and then go into your question. And they've all been willing to stay and take your question. So does anybody have a question or comment?
Hi, my name is Arthi Sruthi. I'm a family physician. I work at Oscar Health. I'm a big fan of the work that you all do. I spend a lot of time with my practice thinking about patient engagement and how I can really improve that for my panel. And I'd love to hear from your perspectives for your respective organizations about what you think the key elements are to promote and increase patient engagement.
I'm happy to start. I don't have anything like earth-shattering to say. I think it's time and trust, and it's time and trust, and people understand what you're saying. They believe that you have their best intentions at heart. They trust you to make recommendations that work for them, and then you equip them with the tools and support that they need to carry out those recommendations. That's a sort of not at all secret holy grail to engagement. And I do think the technology can be really helpful in driving that and giving us as providers tools that help maximize engagement. But there's no substitute for trust and for a longitudinal trusted relationship in primary care.
Yeah, pretty significant ditto on that. But the only other kind of nuance as a practitioner is you don't realize how much friction there is sometimes to get to you. So being aware of all the other elements that restrict that interaction can also be a factor to look at.
Just on that point, we've made a big push at CareMore to bring care outside of the clinic in the last 2 years. So we now have a fully home-based primary care team in Connecticut, and we've adapted all of our models and markets to increasingly incorporate a mobile care team. And I think we just forget, like Tom said, that we're asking people during moments of need when they don't feel well, or things where there's some cognitive mismatch between immediate value to them and our concept medically of long-term value to them clinically, that we just actually have to go to them. And so CareMore has kind of since the beginning gone to its patients in the ERs, the hospitals, the nursing homes, and we're now doing it more systematically in the home. And like Toyin said, I think you've got to meet people where their other needs are being served. So going to jails, going to psychiatric facilities, going to food banks, going into community settings is important. And I'd say our teams are reaching a tipping point where many of them are spending either 100% or at least 40 to 50% of their clinical productivity outside of the clinic.
Hi, I'm Radia. I'm a primary care internist at an FQHC in New York City. So I'm very much in the broken system, approaching the burnouts. And I think what I wonder working at an FQHC and hearing about CareMore, hearing about Cityblock is, can that be funneled down to our system where we see a majority of the Medicaid, Medicare population? And if we want to disrupt healthcare and have impacts, that's where we need it.
I think FQHCs and community clinics are the unsung heroes of healthcare. If you look at what's going on with the opiate crisis, with poverty, with increased rate of death among people in middle age in America, very broadly, there's really only kind of one structure nationally that's granted clinical resource, and that's through the FQHC framework. We have creative thoughts about how to partner with FQHCs. I know there are a lot of constraints on the legal and financial side. And so I think it's an area where if there could be kind of more expansive policy reform, there might be an ability to kind of even deepen that kind of work.
Sure. So your point is really well made. So add us up together together, Vivek's taking care of 90,000 people across the country. We just got started. I know Tom's going to build something big, but collectively, I think at best we're talking about addressing maybe 0.5% of the, tens of millions of people in this country who need effective primary care. You think about, there's 9 to 10 million people who are dually eligible for Medicare and Medicaid in the country, and probably about, 10 to 15 million Americans who are Medicaid covered who have significant physical disabilities and mental health needs. Those folks are getting care in facilities and institutions like yours. It's a huge part of our model and our approach to think about how we effectively partner with federally qualified health centers, independent practices, to bring our care model and effectively meet providers where they're at. And so we certainly have thought about that, have baked it into our business model as well as to our clinical model in ways that allow patients, to the extent that they have trusted relationships with their primary care provider, and it may be the doctor, it may be the MA at the front, the MA who checks their vitals, the person at the front desk. If this is the place where they connect with services, we think of that existing primary care relationship as something that is valuable and worth preserving, and believe that through our affiliated care model, so the additional parts of our care team, our nurses, our field-based community health partners, our connections to social services, we can help those providers more effectively meet the needs of their patients. So I completely agree with you, and it's certainly something that we are working really hard on.
Hey, I'm Alden Gordon. I'm the Director of Analytics at RubiconMD, so obviously I'm concerned about the numbers. So all of these models require a lot more like PCP supply, longer appointments, more frequent appointments, more time spent coordinating care. And I mean, we have a PCP short in this country, so I guess the question is, I mean, do you agree that number of PCPs is going to be an ongoing issue as these models scale? And if so, obviously outside government intervention to like change the incentives for medical students, what can the people in this room do to address that?
I got stuck with the microphone on that one, but so I haven't done all the number crunching on the primary care shortage, but I know from my quick scan, I'm not fully on that boat. I do think there's a huge provider mismatch where they are. And I do think technology bridges the mismatch a lot more. So the constraint is not necessarily the supply, although it is a factor for sure. It's really the payment models that enable the better distribution of the care to the right people. That's one dimension. And frankly, looking at technology to automate and kind of distribute some of the low-hanging fruit off of the primary care provider's plate so they can do actually more of the heavy lifting work that's of value. So that's true of all specialties. That's true of all degree types. And at One Medical, we saw that in spades. Like, just the amount of work that any individual caregiver and/or administrative personnel on our team was doing was just a lot of wasted, repetitive work. And so the more you can automate that and put it into technology, the more that you can actually leverage the resource to do a lot more higher volume work and higher throughput in terms of value.
The only thing I'd added, it's been more of a recent thought, is if you look at our public health infrastructure and how we educate people to care for themselves, we're way at the bottom in terms of scale and impact globally among similar countries. So in my practice, I remember seeing so many people who we would joke a little bit. You basically need a mother. You move to New York, you're stressed out, you've got a big job at maybe RubiconMD. We're working a lot on maybe analytics, not sleeping, having lots of couscous and hummus, and yeah, it's very stressful. But seriously, I think there's if we think about what we all learn in our lives about how to care for ourselves, how to provide self-care, it's been accentuated now as a parent. Just even as a physician, you kind of freak out about all the same stuff. But that produces a lot of low-level utilization that could be self-care or probably virtual care enabled when needed. And I think that burden it falls on primary care, and there's just so many common sense things that there's probably a better amplification method for.
Hi, my name is Omar. I'm a medical student at Mount Sinai, and I had a question about the recent announcement from the Trump administration to roll back risk adjustment. And I'm wondering, if you think that sort of poses an existential threat to your business and how you guys think about risk stratification.
It's deep. It's deep, man.
Sorry? Incoming first year.
So I'll try stab in. I think it's limited to the ACA, which is the individual exchange and small group. So Oscar, I worked at, and there were a couple layers to the risk adjustment, but the primary steady state mechanism is a transfer based on assessment of each health plan's risk of their population. So that mechanism seems at risk for the individual exchange, and just personally, I really was upset about that because you see it in Medicaid, you see it in the uninsured population, and you see it in the individual exchange population that people really do stint on basic and also very significant healthcare needs. So I remember expanding into Texas at Oscar, and day one, people were being admitted to major hospitals because they finally got insured for the first time in years, and they were listed on the liver transplant list a week later. And so there's just huge pent-up demand. There's a complete mismatch of timing of the rightness of care, the size of care, who does it when. But I think Medicare Advantage, which has a very well-established national risk structure, is probably not at risk, unless you read something I didn't. That's Medicare Advantage is a huge growth area for health plans. I think about 35% of the Medicare eligible population is on Medicare Advantage construct, which I imagine most people know, but just is a private health plan providing the Medicare benefits, and they get a global payment, and then they organize the network and pay out for the medical costs through it. So it's not fee-for-service to each clinical group or hospital providing each episode of care. And I think that's almost an analog for maybe a better risk adjustment mechanism that maybe should be incorporated to more of the health insurance schemes. But
Yeah, I don't disagree. I mean, I think in general, a lot of the exchange stuff has a lot of political charge, but practical charge to most organizations is not a dominant needle mover, outside of perhaps the shift back to uninsured. So that does impact hospitals and other systems that bear that burden. But from a pragmatic perspective, I think there's enough stability in Medicare Advantage and other kind of forms of payment across commercial and/or government channels that it's not an existential threat to kind of frame it, but it does kind of add some turbulence to a portion of the market.
Yeah, I would agree with everything. I mean, particularly in Medicaid, where risk adjustment is nascent, if at all. It's very heterogeneous state by state, and frankly, I think we lack the inputs into most models to actually drive effective risk adjustment based on administrative data. There's just a lot to be done there, and I think that the onus on sort of downstream entities rather than regulators to do that work, to understand as an MCO, as an at-risk provider, how you stratify your population and effectively create a risk pool that allows you to titrate care and services to folks who need it. That continues to be present as we continue to try to make the economics work within those products. And then to the point about Medicare Advantage and duals products, that is a really well-established structure that doesn't seem to be in jeopardy.
Hi, my name is Alan. I do data analytics in healthcare data. And for healthcare data, my question was, how useful do you find the use of telemedicine? How useful do you find the use of telemedicine in your work? Because a lot of Americans don't live in New York City or don't live in large cities where, like you say, you're tripping over specialists or PCPs on every single block. So for most people, it's like 30 minutes to an hour drive to the nearest hospital or to the nearest clinic where they can find medical care. And I was wondering, how useful do you find telemedicine to sort of reach out to those people or to people who can't physically get out of their house?
Sure. I mean, I would just start by maybe tee these folks up by saying I think we've barely tapped the tip of the iceberg on the potential of telemedicine for improving access to care. I think I think, though, we have to, particularly for the types of populations that we serve, for folks who are underserved, who have a lot of trauma, a lot of social needs, who perhaps are, they have smartphones but are not as tech enabled as people who are in, accessing commercial insurance. We have to think differently about how we deploy telemedicine. I think it's unreasonable to expect that someone, with multiple chronic illnesses and a disability who's living in, low-income housing is going to tap into an app, sort of sight unseen to access care. However, I think as part of a high-touch clinical model, I think it's a really, really powerful tool. It's certainly something that we're exploiting in our model, even in urban spaces. And so I think, as you think about the great statistic from, not great, but really apt statistic from Central Brooklyn, for example, is that only 11% of practices, primary care practices in Central Brooklyn, have like walk-in availability after hours and on the weekends. So even where we have an abundance of providers, we don't actually have 24/7 access. Telemedicine can be a really powerful tool for that as well. And so I think this is it's just the very beginning. Certainly has been hampered by payment structures and models like that. But in value-based and risk-based models, we found there's tremendous value there.
Yeah, the only thing I'd add is that we've been asked to launch plans to go into more rural areas because in many rural areas, poverty and other factors that contribute to poorer health and more clinical risk align with geographic disparities, lower density, and then a lack of effective access to healthcare. I'm not sure anybody's really cracked that nut. It's been something we've been puzzling about. One thing we're experimenting with is levering kind of the access through telemedicine, so sending a community health worker or medical assistant to patients' homes and augmenting them with real-time consultation from one of our nurse practitioners or physicians. And again, that's part of trying to make things work and be sustainable from the reality that somebody has to pay for this stuff to happen, but also getting more care to people where they are.
Yeah, sure. So we have a question submitted online which says, if value equals quality plus service over costs, how are you measuring this? Value equal quality plus service over costs.
Yeah, I mean, look, there's the theoretical, and then there's the pragmatic. We're working on the theoretical in my new org, but it's too early to kind of discuss the formulas. But in a pragmatic world, value is at least doing the same level of care that the current system does at lower cost. And that's a pretty low benchmark, I think. And then if you apply appropriate resource, you can improve some surrogates of quality, which is the fuzziest thing, but where people most get charged about quality metrics. So you can show some surrogate quality metrics that improve and hopefully maintain costs or decrease costs. So that's how quality and value are measured on the pragmatic side. It's obviously far from perfect. I mentioned the risk adjustment model creates a lot of vagueness as to that. They're very proprietary voodoo black box type of models that most people would say, but at least everybody's using a standard or two that they can measure, but it's an imperfect science.
Just quickly to add, they added specifically in your organizations, how are you measuring the value of what you are providing in your organizations?
Yeah, I mean, I would echo Tom's point. I think there's the very pragmatic kind of table stakes of doing this work in this world. We have a capitation, we have a projected cost, we have a medical expense ratio, we have all of these kind of very well studied, defined measures for cost. And then we have a very imperfect and very dissatisfactory slate of quality measures that we use as a set of guardrails against that. So we have to at a minimum meet that threshold, and that's something that we pragmatically are striving to do, and the success of our business very much depends on the ability to do that. I think more broadly, there's a lot of really interesting and important questions about what value is and to whom, and how we measure that, and how we frankly reframe our understanding of what value is in the healthcare system, and whether I should have ended that sentence with healthcare system or in society or communities or to our population as a whole. And we're really engaged in those conversations as well, in thinking about how you measure patient-centered quality, how you incentivize teams towards that, how you think about the amount of investment in building trust and relationships, how you think about longevity as an outcome that is really poorly measured by any of these models, right? If somebody is a high-cost beneficiary or a high-cost member and they die, actuarially their costs have stopped. If we are prolonging life, there's no way to financially account for that as being a value in itself. The value that to a family member of having their loved one still there, to a child of having a parent, to a community of having a productive member of society. It gets really meta really fast. So I'll stop there before we get down a rabbit hole. But I think it's an interesting question and incredibly nuanced and probably too hard to answer in a brief 30 seconds.
It's fun to think about.
So this is Carlos Reines, one of the founders of co-founder of RubiconMD. In building RubiconMD, biggest learning has been the importance of the talent. We've been incredibly lucky to surround ourselves with super talented individuals. And I've noticed this in your organizations. Been lucky enough to be exposed to the people who work with you, and they are all, particularly clinicians, they are all incredibly motivated. They are go-getters, A+, and I think that's a reflection of you guys being incredibly charismatic and attracting them. My question is, how do you scale that? Do you get to a point where you run out when you need to have thousands of primary care clinicians to find a way to you help transition to your model and adopt it quickly?
Yeah, we interview a lot of people. We are hiring too, by the way, in 10 states. And just a side note, we talk about clinicians, but I think the best business people, operators, analysts want to work with the people most oriented around patients, and the best clinicians. I think there's a virtuous cycle there. Spend a lot of time interviewing, selecting people based on intrinsic motivation, behavioral traits. It's something where you have to unpack the layers of the standard. Hey, it looks nice to meet you, to go into the motivation. And so I think we now select better up front, but really focus more of our initial interviewing on that intrinsic motivation, because I think when you come to work every day and people are all about the mission that you're set up to organize and drive against, that just creates lots of added value, lots of added thoughts, but it takes a lot of intentional work up front. If you don't hit that, then people who are that way feel like they're misaligned. They feel like they're not getting the same kind of recognition and validation for the same things. They have weird interactions with other people on the team. And so it has to reach a level of consistency, which takes a lot of work.
Yeah, kind of my maybe two threads would be culture. Clinical culture is really important. I think docs can sniff out a business culture or something kind of more nefarious. So I really think that's critical, and it's hard to fake. So you really have to be authentic about supporting clinicians, supporting patients, and be authentic. And then the separate thing is just process. Like it's just like anything else. Nothing happens for free, and you got to invest in good process and good thinking and a lot of hard work.
Yeah, I would add just one thing. I agree with all of those. I think there's a broader question for us about how we can get upstream and thinking about education, not just for physicians, but for other health professionals, how we start to get far, far, far upstream and take people when they are at their most idealistic and most joyful and most kind of excited about this work, and help preserve that through the rigors of what is quite a toxic medical training system, and put them in proximity with people who are not physicians, who are nurses, who are social workers, who are behavioral health specialists, to start to build that interdisciplinary learning and that capability set. Ultimately, we are going to start to hit the bottom of the barrel if we're not really investing upstream in the next generation of clinicians and non-clinicians who are going to be caring for our patients.
So, okay, we'll take one last question. Can you give the Well, because we're streaming, so we want people to be able to hear. Yeah. Okay. Yeah. Thank you.
Online community. I'm here. My name is Diana Ramirez. I'm a family physician. I want to make a question and a comment regarding the primary care shortage, which I argue that we don't need more primary care physicians. I think we need to redesign the medical teams or the healthcare teams. I work with undocumented women in Queens. This is a clinic that provide very low-cost services. We do all the primary care, labs on site. We do wellness activities, yoga, Zumba, mental health on site with community health workers. So I'm the medical director, and the community health workers run the clinic. In a lot of the clinics, the community health workers serves as a bridge between the physician and the patient. Here, they run the clinic. So we train them to do population management. We train them in preventive care. I see myself as a facilitator. And they run the huddles. They design the strategies to improve diabetes care, hypertension. And I can say that, for example, our hypertension control is 85%. And this is patients who don't have insurance. So I argue that probably we need to redesign the teams. We need to really trust in other staff members that can leverage and work with patients. And maybe we need to stay back as physicians in primary care and really work with communities. And I think telehealth has a huge value in this. A lot of my patients, even if they have a low income, they use smartphones and they use Facebook all the time. So we do a lot of Facebook Lives. We probably were not that HIPAA compliant, but at this point already care. No. The good thing is I had to pay with insurance, so I can break the rules. But we see how valuable it is to foster relationships. So we do a lot of WhatsApp. And what I'm finding, the barrier for the patients, I have patients who are even illiterate in Spanish. So the barrier is not the technology, it's the payments. Sometimes they run out of data or they have a very limited plans, but they are, they use the smartphones, everybody tracks everything, their friends, whatever. So I think we need to get involved in this. But my question is, we depend on charity. So I had to report outcomes, and we report, good outcomes with hypertension, diabetes, preventive screenings. But I think we need to redefine what are the key metrics and how we define those key metrics. Access. So we are tracking all the text messages because people love to text. We're tracking the phone calls, how quickly we respond, so access. But I think how is that we can track trust and how we can trust engagement. I don't carry my patients because they are obsessed about hair, like losing their hair. I don't care if they made tons of appointments for hair loss. If I can discuss with them the important things. So for them, there's access. But how is we had to redefine those metrics. And I wonder you have something that can share with us about defining those key metrics. And I thank you so much, Rubicon, for putting this panel together. It has been really fun.
Thank you so much. That was really inspiring and amazing to hear you talk about your clinic. And you touched on so many things. I mean, we similarly in our model, community health partners are the mainstay of our model. These are folks who do not have any clinical licensure. They're hired for empathy and for problem solving, kind of grittiness, for trust, worthiness, and for their kind of tenacity. And we train them on everything else. And they are out there in the community, meeting people in coffee shops, in their homes, helping them solve problems of daily life and starting to build a bridge to the healthcare system. And so I absolutely see the value there, and that resonates a lot. I think your question about how we measure trust is something that I've spent a lot of sleepless nights thinking about, and I think we're starting to build a slate of kind of proxy measures for that. So certainly, there's actually no validated tools out there. There's a healthcare measure of distrust that is actually quite powerful. It is very, very highly correlated with poor health outcomes, a high score. And it's questions like, do you think that the healthcare system would, do tests on you without your knowledge? True like mistrust. But the converse, the positive side of that is really hard to measure. And so we have a bunch of kind of slates of tools that we use, using things like inbound messaging versus outbound messaging. So do people reach out to you? Versus you to them? Does that change over time? Are we chasing them and then they come to us? Questions about, the amount of information people share and disclose with you over time as a proxy for trust. Certainly longevity and the continuing like time of a relationship and a relationship with a single person in the health system can be a useful measure. And then there's no substitute for direct to patient surveys. But I think over time, as the currency of our healthcare system moves from transactions, number of visits, number of things we've done, clinical endpoints, to true value to people outside of the healthcare system, those questions become really interesting and really important. And I think we're not there yet, but we're certainly thinking a lot about it.
Well, on that note, thank you very much to our panel, and thank you to all of you.